So I'm Osei Kankam, I'm respiratory consultant at Conquest Hospital. And this presentation is with my colleagues on Newington Ward, who have all come together to contribute to this presentation. So I have Alanis and Isabel with me here today. And then the others, unfortunately, are off because of nights, etc. So what we'll talk about today is I'll do this just to introduce. I'll do a couple of case histories, give an evidence base for the diagnosis we come up with, and then I'll talk about the patient outcomes and then summarize what we learn. So our first case is a gentleman, he's 64-year-old, admitted on the 15th of December. 2-week history of cough and breathlessness. Rather extensive past medical history. He was unvaccinated, and he lived alone with no package of care. So on initial examination, he was tachypneic, tachycardic, mild expiratory wheeze held in chest auscultation, temperature normal, cardiovascularly stable, heart sounds were normal. His initial early warning score deceptively was 3. The investigations that were performed included renal function, which is essentially normal. CRP was marginally elevated. Lymphopenia, spike protein antibody was low, greater than 250 is considered to be a good response. Procalcitonin this is 0.06, which is low, but the ABG showed a type 1 respiratory failure, and his COVID PCR swab was positive. And so the diagnosis for this gentleman was reached after we looked at his chest X-ray, his bloods, and his presentation. So we said it was a COVID pneumonitis complicated by type 1 respiratory failure. The 4C score is from the ISORAC UK data on COVID pneumonia and has been in operation since March 2020. It's a derived score that helps us predict the risk of death from inpatient admission and the risk of deterioration. So for him, we can see that the risk of deterioration was close to 80%, and his risk of death was just over 40%. So this chap is somebody we need to treat with a lot of attention and care. So these are the evidence-based treatments that we offer. Dexamethasone based on the recovery trial, intermediate dose Clexane because of the risk of thrombosis. Remdesivir is given early within 10 days, then it impairs viral replication. Antibiotic therapy indicated for secondary bacterial infection. And the Ronapreve is a combination of 2 monoclonal antibodies against the spike protein. And because his was low, this was supposed to boost his response to his humoral response and the immunological response to the infection. So this is pretty standard therapy, except that now with Omicron variant, we don't use Ronapreve anymore. We tend to, if we need to and we prove it, we can use sotrovimab, I think, instead of Ronapreve. This is only useful for Delta variant. And then on the 16th, he had a med call. The issues were that he had severe worsening type 1 respiratory failure, increased oxygen requirement. He was put on CPAP with 10 liters of oxygen, and because of his prior level of fitness, etc., he was deemed for full escalation. Now, this gentleman was, with further deterioration, transferred to intensive care because he was becoming tired. And on the intensive care unit, he was given high flow nasal oxygen. He had CPAP therapy from time to time, but he didn't require intubation. And so was stepped down back to the ward after about 5 days. Unfortunately, the day following day of returning to the ward, he desaturated with SATs of 81% on very high flow oxygen, blood pressure dropped, and he was complaining of chest pain. We arranged a portable X-ray. Now, our differentials in these circumstances was that had he had a PE because he'd been in hospital, not on treatment dose of Clexane? Did he have a pneumothorax? Because we know that people with COVID and severe respiratory failure can have pneumothorax, can develop pneumothorax, or had he aspirated because he had been eating a meal? Now, this is what our X-ray showed us. So, and for comparison, I will show his X-ray on admission. So we see the X-ray from the 15th of December and the X-ray on the 24th of December. We can see that he appears to have a bit more pneumonitis, the infiltrates on the subpleurally. But interestingly, there is a very sharp demarcation around the heart. And this is a sign that there's a possibility of air in the mediastinum. So we can see this one, and that's the sign that we see here. So we arranged a CT scan, and the CT scan clearly showed that there's air in the mediastinum. So this is a pneumomediastinum which has happened to this gentleman. So this is the CTP report. So he had no PE, but he had a pneumomediastinum with no cardiovascular compromise, and the typical changes that we see in COVID. So we had a confirmed pneumomediastinum. CPAP therapy is not indicated further in these circumstances because he wasn't the condition. So he returned to intensive care for ongoing care. And I'll come back to him later on. So we have a second patient. He's also in his 70s, admitted on the 13th. Breathless, fever, vomiting, unwell, history of angina, on atenolol, unvaccinated. So it's another 70-year-old gentleman who is unvaccinated. He lived in a warden-assisted accommodation. So he was tachypnic, hypoxic, and had bilateral coarse crackles on chest examination. His lymphocyte count surprisingly was normal. PCR test was positive for COVID. He had a Delta genotype. His SARS-CoV-2 spike antibodies were low, and his procalcitonin levels were slightly elevated. That was his chest X-ray. Here again, you can see the subpleural changes on both sides. Our diagnosis again is COVID pneumonitis complicated by respiratory failure. 4C score, his risk of death is higher than the one we did, and his risk of deterioration is higher than the other gentleman. And this will be borne out in future, in the course of our presentation. So CO2 is conventional oxygen therapy with a target SAS of above. So standard therapy with dexamethasone, remdesivir, we gave him Ronapreve. He was a right delta, we gave him IL-6 inhibitor, saralimab. He had Clexane prescribed prophylactically. And then very soon after, we had to put him on CPAP therapy because of ongoing hypoxemia and an increased work of breathing, despite 15 liters of oxygen. Day 6, he was persistently hypoxemic on CPAP. No improvement even when we adjusted the FiO2 CPAP pressures or semipronin. But then he constantly was complaining of chest pain, which had not been a complaint in the preceding days. And we noticed that his D-dimer had also gone up, but we know that it goes up with COVID anyway. So his D-dimer was up, he was persistently hypoxemic with new chest pain and difficult to manage on his CPAP settings. So we've got our differentials here again were very similar to the previous one. Is it a PE, which is prone to, is it disease progression? He's unvaccinated, multiple comorbidity, so it won't be surprising. He's been in hospital for close to a week. Hospital-acquired pneumonia is a possibility. And then the other thing we thought about was aspiration pneumonia because he sort of enjoyed his food. So we did a chest X-ray. Now, over here, is a lot more clearer than the previous one. You can see a very sharp demarcation around the heart, very, very sharp demarcation. And if I show this side by side with the admission X-ray, so this is his admission X-ray, and this is his day 6 X-ray, and you can see the sharp demarcation here. So he also had a confirmatory CT scan, and it's very clear that there's air around the whole mediastinum, going right up to the trachea, and you see the same thing here. So he also has a pneumomediastinum, but sadly for him also had bilateral Ps. Fortunately, there did not seem to be any, what do you call it, cardiovascular compromise. The reporting radiologist speculated that he had also a tracheal diverticulum, and he thought that it may have ruptured into his mediastinum, but it's only speculative. And before we carry on, there are 2 questions that I thought I would touch on very briefly. Why do we use CPAP therapy in COVID pneumonitis and respiratory failure? The main reason why we will use CPAP therapy in anybody with severe respiratory failure and pneumonitis such as COVID is that we want to reduce the work of breathing. We want to promote alveolar recruitment, and by so doing improve reverse hypoxemia and reduce intrapulmonary shunting, which contributes to that. And then there's also the cardiovascular effect. And Dr. Christopherson has a very good resource on CPAP using what do you call it, COVID pneumonitis on intranet site. I'll show some information on that. This is where we get it. It's a very useful resource. So our next bit, as I said, is we will touch very briefly on the evidence base for the use of CPAP therapy in COVID-19 treatment. And so Isabel will take over from you.
Thank you. So I'm going to speak about 2 randomized controlled trials performed on the use of CPAP in COVID-19. There's also a lot of lower grade evidence out there, including several cohort studies, but I've selected the 2 randomized controlled trials to speak about. And before I come on to this, just to mention some of the types of CPAP we'll be talking about. On the left, we have the CPAP mask, and on the right, the CPAP helmet, which we'll come on to. So the largest of these 2 trials is the Recovery RS, or Respiratory Support Trial. This sought to clarify the efficacy of continuous positive airway pressure, or CPAP, and high flow nasal oxygen in the treatment of respiratory failure due to COVID-19. It was a multi-center, open-label, randomized controlled trial that compared CPAP, high flow nasal oxygen, and conventional oxygen therapy. Inclusion criteria were adult hospitalized patients with known or suspected COVID-19 with acute respiratory failure, which was defined as peripheral oxygen saturations of 94% or less, despite receiving an inspired oxygen fraction of at least 40%, who were also deemed suitable for tracheal intubation if treatment escalation was required. These participants were randomly assigned to receive either CPAP, high flow nasal oxygen, or conventional oxygen therapy. 1,272 participants were randomized over a period of 13 months from over 70 hospitals. The primary outcome was a composite outcome of the need for tracheal intubation or mortality within 30 days of randomization. This primary outcome was significantly reduced in the CPAP group when compared to conventional oxygen therapy. So about 36% of participants who were randomized to CPAP compared to 44% of those that were randomized to conventional oxygen therapy met the composite outcome of tracheal intubation or mortality 30 days post-randomization. And this translated to a number needed to treat for CPAP of 12. The reduction in this composite outcome was specifically due to a decrease in the incidence of tracheal intubation. There was no statistically significant difference in the mortality rate at 30 days between the two groups. For high flow nasal oxygen, when compared to conventional oxygen therapy, no effect on the primary outcome was seen. So, as the previous slide, neither high flow nasal oxygen nor CPAP reduced mortality at any point versus conventional oxygen therapy. And looking at the secondary outcomes in this trial, for CPAP versus conventional oxygen therapy, ICU admission was significantly less with CPAP, 54.1% versus 61.5%, and time to intubation significantly longer with CPAP. But no significant difference was seen in the duration of mechanical ventilation, critical care length of stay, or hospital length of stay. And for the comparison between high flow nasal oxygen and conventional oxygen therapy, no significant difference in ITU admission, time to intubation, duration of mechanical ventilation, critical care length of stay, or hospital length of stay was seen. And it was noted that the trial wasn't specifically powered to detect differences in mortality. In addition, crossover between the treatment arms, which would be a patient receiving CPAP or high flow nasal oxygen when they weren't originally randomized to that intervention, might have reduced observed effect size. Also worth noting that the decision to commence invasive mechanical ventilation wasn't standardized, and it's possible that the lower rate of intubation in the CPAP group was due to clinicians being more willing to delay intubation for those, and it was indeed noted that time to intubation was greater in this group, so this effect wasn't seen with high flow nasal oxygen. However, basing the initiation of invasive mechanical ventilation on clinician judgment is perhaps more representative of general practice and might make the results more generalizable. And then moving on to the second trial that I'm going to speak about, the Henivot trial, which looked at the effect of helmet non-invasive ventilation compared to high flow nasal oxygen on days free of respiratory support in patients with COVID-19 and hypoxemic respiratory failure. So it was a randomized controlled trial conducted in 4 intensive care units in Italy in 2020. It had 109 participants with moderate to severe hypoxemic respiratory failure due to COVID-19, and they were randomly assigned to receive either helmet non-invasive ventilation or high flow nasal oxygen. Treatment failure was defined as the need for endotracheal intubation, and the decision to intubate was based on a predefined protocol, unlike the previous trial. The primary outcome was the number of days free of respiratory support, which would include high flow nasal oxygen, non-invasive and invasive ventilation within 28 days of enrollment. And they found that helmet non-invasive ventilation compared with high flow nasal oxygen resulted in no significant difference in the number of days free of respiratory support within 28 days. However, the rate of endotracheal intubation was significantly lower in the helmet group, with 30%, than the high flow nasal oxygen group, with 51%. No significant difference in mortality was seen between the two groups. So the findings of these two trials suggest that non-invasive ventilation may reduce the rates of intubation, which is of importance given the related complications of invasive mechanical ventilation, and is of importance with implications for resource allocation when managing COVID-19. Thank you.
So the next thing we're going to talk about is the complications of CPAP therapy in COVID patients. So the main one is that they sometimes are unable to tolerate the CPAP therapy, where then they would lead to death or the need for intubation. Others include vomiting and aspiration, aerophagia, hemodynamic instability, and the pressure effects of the mask. So you can get pressure sores on the face. The other ones is barotrauma, which include pneumothorax, pneumomediastinum, and surgical emphysema. It's interesting to know that for patients who had failed CPAP and then go on to require invasive ventilation had a lower survival rate. The International Multi-Center HOPE COVID Registry showed that 20% of those patients were treated with NIV, and however, around 40% died, and 15% of the patients that went on NIV then later required invasive ventilation, and these group of patients had the lowest survival rate. If we look at the recovery trial and the incidence of complication, they compare the incidence of complication between CPAP, conventional oxygen therapy, and high flow nasal oxygen. So CPAP has the highest rate of device intolerance of around 6%, and highest rate of hemodynamic instability in comparison to the others, and pneumothorax is slightly lower, where pneumomediastinum is significantly higher in comparison of 3.2% versus 1.1 and 0.1%. So what is pneumomediastinum? It can be defined to separate to spontaneous and secondary pneumomediastinum. And a spontaneous pneumomediastinum is a result of a sudden increase in intrathoracic pressure that causes a subsequent increase in intraalveolar pressure, leading to its rupture and leakage air throughout the interstitium, bronchosvascular tissue sheath, and mediastinum. And secondary pneumomediastinum is often caused by blunt trauma, penetrating trauma, or complication of surgical intervention in the esophagus or the tracheobronchial tree, intubation, or invasion by gas-forming bacteria. And in terms of pneumomediastinum, and specifically COVID patients, is seen to be more common in mechanical ventilation compared to non-invasive ventilation. And there's a direct correlation between positive airway pressure, the PEEP, and the incidence of pneumomediastinum. Multiple cases of COVID-19 associated disease have been seen, and they're more prevalent in COVID-19 infection in comparison to ARDS. The clinical features of COVID pneumomediastinum includes pain, chest pain, neck pain, throat pain, cough, globus pharyngeus, so the persistent feeling of swelling of foreign body in the throat, increased work of breathing, and dyspnea and choking, and increased oxygen requirement. Sometimes they can also get surgical emphysema, where you can have facial and neck swelling, and cardiovascular compromise as well. These effects, if we don't recognize pneumomediastinum early, if left unrecognized, could lead to tension pneumomediastinum. So it's quite similar to a tension pneumothorax, where air enter the pneumomediastinum through a valve-like mechanism, but unable to exit, causing it to be a tension pneumomediastinum. Secondly, the retained air may result in reduce in lung capacity and secondary atelectasis, as well as compression of the right atrium and vena cava, causing hemodynamic instability. Boerhaave syndrome can also occur, where esophageal rupture and cause gastric content to spill out, causing mediastinitis and sepsis. And in terms of the management, the gold standard for diagnosis is a CT scan. It is usually benign with good prognosis, and it will require a multidisciplinary approach with thoracic surgeons' input if necessary. And there's no BTS guidelines about this currently yet. And therefore, the treatment is focused on symptom relief and close monitoring for signs of conversion to tension pneumomediastinum and pneumothorax. So first of all, you have to stop the CPAP, and if they are under mechanical ventilation, we need to readjust the PEEP and the tidal volume and to wean off mechanical ventilation. Secondly, have to give adequate analgesia. And thirdly, for oxygen therapy for reabsorption of oxygen and displacement of nitrogen for those air spaces. In terms of the evidence with COVID patients, the incidence of barotrauma, there's only several case reports about it, and it ranges from 4.7 to 8.1% of barotrauma and NIV COVID patients. In Liverpool, in a very small study, they've seen the incidence to be 0.9% during wave 1 and 6.6% of in wave 2. All these patients subsequently develop pneumomediastinum, and in 5 out of 9 of those patients with pneumothoraces. And in those 5 patients, there's actually 100% mortality as well.
So this is Osei Kankam taking over again. So we've talked about the evidence base for CPAP. The recovery trial is the most robust trial in the world at the moment about the use of CPAP therapy. It's not fully published yet, but it was live UK data. And I think the take-home, the main message from that is that CPAP therapy is effective if it's used at the right setting early on in the disease process, and prevents people going to intensive care and the implications and resource in the sort of time and resource implications of that. And then high flow nasal oxygen, which was pioneered a lot previously, is useful but is no superior to conventional oxygen therapy based on the information from these 2 trials. It also tells us that if you use a helmet instead of a face mask, it's effective. Just to summarize what happened to our patients. So I showed you about these 2 patients. I showed information about them. So the first one was admitted, went to intensive care, came back to the ward, developed pneumomediastinum, went to intensive care, was managed with high flow nasal oxygen, returned to the ward after about 3 or 4 days, slowly weaned off oxygen with physiotherapy, and then eventually after about 24 days in hospital, we were able to discharge him with no residual problems. The second one had both a PE and pneumomediastinum. CPAP was stopped. We will give him high flow nasal oxygen with good response. He couldn't tolerate the conventional oxygen. And then he seemed to do well for about 10 days, but then developed a mechanical intestinal obstruction due to constipation. He became less well, stopped eating, deteriorated, and unfortunately had to be put on an end-of-life care pathway, and passed away about 20 days into his admission. So what are take-home lessons for what we've talked about today? We should consider pneumomediastinum as a cause of acute deterioration in COVID-19 patients on CPAP therapy, especially when this happens out of hours. Pneumomediastinum can be difficult to distinguish on the chest X-ray alone, and it's always useful when you think about it to know that the CT scan is the gold standard diagnostic tool. The evidence base shows us that it's not necessarily always associated with a poor outcome, but diagnosing it allows us to modify the kind of treatment we give to a patient. So just to go back, if we CPAP therapy resource is available on the intranet, so please you can type in CPAP, COVID CPAP, and this comes up, and there's some fantastic training material and videos, and it's also available on YouTube. Just to summarize, so we've presented 2 cases of medium mediastinum complicating CPAP therapy in 2 unvaccinated COVID-19 patients. Interestingly, they were both in their 70s and both lived in Hastings. We've talked about the evidence base for CPAP therapy and some of the complications that can happen. We have touched on pneumomediastinum and how we manage it. I must say that we have confined our management to pneumomediastinum as one would see in this context, because medium mediastinum can present entirely benign in the pediatric population where you do nothing at all. Can present in asthmatics where you do nothing at all. And if it happens as a result of trauma or burn injury, thoracic surgeons will deal with them. So our management plans have been confined to the context in which we did our presentation. And it's a much wider discussion about pneumomediastinum, and there I give a few take-home lessons. So I've come to the end. We've come to the end of our talk, and we'll be happy to take questions. I don't think you've seen our faces, so we'll make our faces available to you to see. It's my colleagues and I. So here are my colleagues. So Dr. Dos, Dr. Mark, and Osei Kankam. So we'll be happy to take any questions. Yeah, please fire away.
Oh yeah, hi Osei, it's Neil Sharma here. Thanks, that was a really good presentation. I just was going to ask for a comment rather than I guess a real question. There's obviously shown some of the problems with CPAP. There's also benefits you've demonstrated quite clearly. Now that we're out of the first sort of 2 or 3 waves, having waves you want to count, I think it's quite clear you mentioned that CPAP is effective if used in the correct setting. I was going to ask you what you think the correct setting for CPAP under the current levels we have would be, and where we should be doing it. Well, I'll put my camera on as well.
I'll defer to the recovery RS trial. It said if the saturations are less than 94% and you are using an FiO2 of more than 40%, that is the time where you should consider the use of CPAP therapy. So I'll just defer to that. But to add to that, there's clinical judgment comes in. So if you look at the acute, but obviously there are patients who physically may not look unwell, but have saturations within a range that is acceptable, but with increased work of breathing and very severe pneumonitis. So in addition to the 40% FiO2 and above, and the less than 94% SpO2, I would add clinical judgment and also the patient's pre-morbid state.
Sure. So thanks. What perhaps wasn't clear. What I meant is that, I mean, on Eastbourne site we have 0 CPAP at the moment. I'm not sure how many you have on Conquest. My question is, should that still be in a level 1.5 area rather than a level 2 or 3 area? And you've demonstrated some of the problems that CPAP can cause, whether we're doing it in the right areas at the moment when we have lower numbers.
Dr. Sharma.
Am I being too inflammatory?
You haven't asked an inflammatory question. I'll provide an anti-inflammatory answer. Yes, I agree with you. I think we have got to a point where we have to redesign the way we treat COVID, the way we approach COVID management. And it's a whole system reset. And yes, there should be dedicated places with the right level of staff and the right knowledge base and resource allocation to manage this group of patients, and not shut down whole areas of the hospital because 1 or 2 patients are having CPAP. So yes, I agree.
Yeah, okay. I'll be quiet now.
Yeah, any other questions, please? Or you could type into the okay. Okay, so yeah, how do you get a risk of deterioration score? The risk of deterioration score is called the 4C score. 4 as in the number 4 and C and score. If you type it into any search engine, it will come up. And there's the ISRAC Research Consortium, which has been doing a lot of the UK-based.
You're on mute, Osei. I don't think anyone can hear you.
Hello.
Yeah, we can hear you.
Can you hear me?
Yes, I can hear you.
Yes.
Yeah, okay. I said the 4C score is derived from information gathered by the ISARAC consortium, which is a UK-based consortium that has done a lot of research into COVID in terms of genomics, antibodies, etc. And the data they've collected from all inpatients in the UK is what generated the score. And it looks at CRP, it looks at age, it looks at comorbidities, it looks at CO2 at presentation, etc. And then once you put in all these figures, it generates a figure for you. And the figure it generates it tells you what the risk of death is based on what you put in and what the risk of deterioration is. And it's a guide because for both patients, we knew when they arrived that their risk of deterioration was about 80%. So it allows you to nurse them in an area where you can react quickly if they deteriorate. And it also tells you about what the risk of death is. So the highest I've seen is 95%. And then for those group of patients, when it comes to communicating with relatives and even with fellow healthcare professionals, you are able to, at a very early stage in the admission, make sort of a holistic judgment about how you're going to manage this group of patients. So if you type in the number 4C into an engine, into any search engine as the ISARAC, you should be able to generate the result. And we always do that and document it in the notes when we see patients for the first time.
Thank you. That was very, very useful. I've always used that for the mortality score. I didn't realize there was a risk of deterioration score on the 4C as well, but that's really helpful. Thank you.
So you're welcome. All right. Thank you very much, everybody, for your kind questions and your attention. And my colleagues and I are very grateful that you have turned up to listen to our talk. And thank you and have a good afternoon.
Thank you. Thank you.
Thank you.
Thank you.